Hello.
Yeah.
Yes, madam, we are live now.
Okay. So I'm starting now.
Yes, you can.
Okay. So hello and welcome all. We are going to today discuss about premenstrual syndrome. So understanding PMS. Not everybody understands PMS, so it is very important to understand PMS. PMS or premenstrual syndrome refers to changes in mood, emotions, physical health, and behavior that develop between mid-cycle and the start of periods. Changes that last until a few days after periods begin. Changes that show up consistently each month. Changes that have some impact on daily life and regular activities. So behavioral and physical symptoms conglomerate is known as a syndrome, and this is known as premenstrual syndrome. So Reed in 1991 gave this definition of PMS, that it is a cyclical condition occurring 7 to 10 days before the onset of menstruation, and it is relieved shortly after menstrual flow begins. Epidemiological surveys have estimated that as many as 80% of women of reproductive age experience one or more symptoms. 50% women will have many symptoms and 20% will have severe symptoms. So this is showing you the commonly reported symptoms of PMS: backache, increased appetite or food cravings, diarrhea or constipation, abdominal pain or abdominal bloating, headache, fatigue, sensitive breasts or pain in the breasts, that is known as mastalgia, nausea, insomnia, or acne. So broadly, the symptoms of PMS are divided into physical or somatic symptoms and behavioral or affective symptoms. And this is the rough distribution. In behavioral symptoms, you can see mood lability, low moods, angry outbursts, depression, hypersensitivity or touchiness, crying, tendency towards isolation or social withdrawal, loss of memory or difficulty remembering, trouble concentrating or confusion. And among the somatic symptoms, you can have changes in appetite. Mostly it is food cravings. You want to eat one particular food in excess. Gastrointestinal discomfort, that is abdominal bloating or pain. Then you can have hot flashes, dizziness, palpitations, or acne. So PMS is the milder form and PMDD is the severest form. Now PMDD is a known psychiatric illness, premenstrual dysphoric disorder. But having said that, PMS symptoms can also be very severe, and they can be severe enough to disrupt a woman's life. So these are the diagnostic criteria for PMS. Now, at least one of the affective and one of the somatic symptoms should be present in the 5 days before menses, during the 5 days before menses, and it should be present in 3 cycles consecutively. Then you can diagnose it as PMS. So you can ask this patient to keep a chart of all the symptoms, and she should come to you after 3 months and bring that chart. And if she has even one symptom from both the categories, then she will be diagnosed as PMS. So affective symptoms, as I told you, anxiety, irritability, angry outbursts, confusion, social withdrawal or depression. Somatic symptoms include breast tenderness, abdominal bloating, headache, swelling of extremities, or changes in appetite. Now, another important thing is these symptoms are relieved from days 4 through 13 of menstrual cycle. So the day of starting of blood flow is known as day 1 of the menstrual cycle. So prevalence in India, this was a study conducted and reported in 2013. And this says that 42% of women face PMS regularly. 58% women face it occasionally. And of the 100 study participants, 68% reported backache, 64% reported leg cramps, 62% reported fatigue, breast tenderness or anger issues. Almost 58% they suffered with anxiety or generalized body ache. Now, etiology of PMS, causes, the exact cause of PMS is uncertain, it is multifactorial, and the exact etiology is not very well defined. However, it is thought that it is the effect of hormonal fluctuations or disturbances a week before menstruation begins. Mainly, decreased levels of progesterone in the luteal phase is said to be the cause for PMS. So other reasons that have been postulated are disturbed function of aldosterone activity leading to sodium and water retention, imbalance of the hypophyseal pituitary adrenal axis, HPA axis, which leads to inadequate secretion of adrenal hormones, disturbed secretion of neurotransmitters like serotonin and norepinephrine, functional hyperprolactinemia, dietary deficits of calcium, magnesium, and pyridoxine, carbohydrate metabolism disturbances. Certain lifestyle factors have also been implicated, like junk foods intake, alcohol consumption, smoking, sedentary lifestyle, obesity, stress, and poor sleep habits or poor sleep quality. Existing mental health conditions will also be responsible for some of these symptoms of PMS. Pathophysiology of PMS. PMS and PMDD are triggered by hormonal events ensuing after ovulation. Although evidence for a hormonal abnormality has not been established, the symptoms of premenstrual disorders are related to the production of progesterone by the ovary. The two best studied and relevant neurotransmitter systems implicated in the genesis of symptoms are GABAergic and the serotonergic systems. So metabolites of progesterone formed by the corpus luteum of the ovary and in the brain, they bind to a neurosteroid binding site on the membrane of GABA receptors, changing its configuration and rendering it resistant to further activation, and finally decreasing the central GABA-mediated inhibition. The lowering of serotonin can give rise to PMS-like symptoms, and serotonergic functioning seems to be deficient by some methods of estimating serotonergic activity in the brain. And therefore, we see that agents that augment serotonin are very efficacious treatment and are as effective even if administered only in the luteal phase of the menstrual cycle. So these are the neurotransmitters involved in PMS. Allopregnanolone. This is a metabolite of progesterone. It is a potent neurotransmitter. It is a positive modulator of the brain GABA receptors. It has bimodal action on mood. High levels are anxiolytic, and low levels lead to emotional lability, that is mood swings. Low levels are seen in luteal phases in PMS, and this implicates impaired steroidogenesis by the corpus luteum. GABA is a major inhibitory system in CNS. Low levels of GABA are seen in mood disorders and during the luteal phase in PMS patients. Serotonin, low levels are seen in the luteal phase in PMS, and the levels are elevated or increased by estradiol, and SSRIs, selective serotonin reuptake inhibitors, are effective for management of PMS or PMDD. Cerebral serotonin transmitter system, 5-HTS. This is involved in a large number of psychiatric illnesses where the affect is disturbed. Gonadal hormone, that is estrogen and progesterone. Gonadal hormone induced modulation of 5-HTS is a known fact. And studies have shown that post-synaptic serotonergic response is disturbed during the premenstrual phase or even throughout the cycle in women with vulnerable trait for PMS. Now, pertinence to genetic factors. It has been seen that 70% of women whose mothers have suffered from PMS have PMS themselves, as compared to whose mothers did not have PMS. Only 37% of these women had PMS. Now, the concordance rate, that is if both the twins have PMS, it was found to be significantly higher in monozygous twins, as high as 93%, than in dizygous twins, only 44%, and in non-twin controlled women, that is no twin pregnancies, that is only 31% had PMS. Genetic influences mediated phenotypically through neurotransmitters, and neuroreceptors seem to play a significant role in the etiology of PMS. So this is a very important slide. This shows the important interactions between the genetic predisposition, genetic traits, genetic vulnerability in a particular person, and how it interacts with the phenotypic predisposition, which is dynamically evolving at all times. So this impaired adaptation genetically affects the serotonergic, GABA receptors, and other CNS systems and processes, and this will affect the person in combination with the environmental states, that is the personality of the person, the emotional states of the person, and the coping skills the person has. And accordingly, she will have the symptoms and the disorder of the PMS. So in conclusion, the pathogenesis of PMS is multifactorial. It has genetic factors, hormonal factors, neurotransmitters, metabolic dysfunctions, lifestyle factors, coping skills, how much they are developed in the person, and existing mental health conditions. So estradiol, serotonin, allopregnanolone, GABA, these are the most plausible etiologies in genetically vulnerable women who will go on to develop PMS. Mastalgia, this is a very important symptom and it is often brushed under the carpet, but this often requires treatment and it should be not ignored. So mastalgia refers to pain in the breasts and it is the most common breast symptom observed in PMS. So it is seen in approximately 60 to 70%. That's a very high figure. It is seen in 60 to 70% women of PMS, and severe form of mastalgia can be seen in 10 to 20% of PMS women. Now, usually women will experience 2 to 3 days of premenstrual mild breast pain. However, around 8 to 30% of them report moderate to severe breast pain, and that too for more than 5 days a month. The affected breast becomes extremely tender to touch and is painful and is often accompanied by swelling of the breast. These are the three main types of mastalgia: cyclic, non-cyclic, and extramammary. Cyclic mastalgia is breast pain which fluctuates with the hormonal changes of the menstrual cycle. So every cycle, the patient will have pain at a particular time. Non-cyclic mastalgia, breast pain is not related to cycle. It is related to some kind of internal anatomical changes, like some injury or some cystic development or some surgery. Extramammary mastalgia has no origin in the breast, but the pain is felt in the breast. So this again describes it in details. Cyclical mastalgia, approximately 40 to 70% of all mastalgia cases will be cyclical in nature. In this case, the pain is diffuse and bilateral with slight radiation to the upper arm and axilla. 30% of mastalgia will be non-cyclical, and pain is generally unilateral and localized to a particular quadrant of the breast. The most common cause for the third type, that is extramammary mastalgia, is inflammation of the costochondral junctions of the chest wall, as seen in Tietz disease, and it will usually subside with rest and NSAIDs. So cyclical mastalgia is seen in 2/3 of women out of all the types of mastalgia. It is bilateral, diffuse, poorly localized, and generally described as a heaviness or soreness that is often radiating to the axilla and the arms. Causes of cyclical mastalgia are these. It occurs most often during the luteal phase as a result of increased water content in the breast stroma, which is caused by the increasing hormonal levels. Cyclic breast pain occurs more often in younger women. Mostly it resolves spontaneously, but sometimes it will need treatment. So increased estrogen, increased prolactin, and decreased progesterone hormone levels or alterations in the estrogen-progesterone ratio are the theories regarding the pathophysiology of breast pain. Main causes: endocrine abnormalities, increased estrogen secretion from the ovary, deficient progesterone production, or hyperprolactinemia. A study from France showed a significantly depressed level of luteal phase progesterone. Peters et al., this is another study, found that patients with mastalgia had a significantly greater rise in prolactin hormone compared with controls. And a study at Cardiff Mastalgia Clinic also reported a rise in stimulated prolactin levels in women with mastalgia. So now we come to management of PMS. Why should there be a need to treat PMS? Now, some women who have premenstrual syndrome have such bad symptoms on the days before their period that they cannot go about their usual activities. So both physical and mental premenstrual symptoms have significant impact on the quality of life of the suffering women. A study of 4,000 women found that 65% were minimally affected in daily life activities, 24% were moderately affected, and 11% were severely affected. So PMS affects a woman's life in every which way, you know, and PMS symptoms may also result in increased healthcare costs and decreased occupational productivity. So there was a study conducted in Anand district in Gujarat. It was a cross-sectional survey of the schools in this district. And as many as 1,700 girls in the age group of 8 to 23 years who had achieved menarche were studied. And these were the results. The prevalence of premenstrual syndrome in these girls was 19.3%. PMDD was seen in 4.6%. In the PMS group, 95% girls had at least one PMS symptom, and as high as 65% had moderate to severe symptoms. Physical symptoms were reported by 53.5% girls. Disruption of daily activities was seen in 41.7% of the girls. 25% had even thought of missing school or college. Majority of the girls felt that PMS was a normal part of menstruation. Now, this is what happens in our society. A girl is often told that ye sabko hota hai, and you just deal with it. But this is quite wrong. And as high as 53% of girls in this study had reported moderate to severe stress levels also. So in conclusion, PMS affects the lives of many women, many girls, and it significantly reduces their efficiency and worsens the quality of life of these girls. Another study was done to determine the correlation between PMS and quality of life in adolescent girls. 180 girls with PMS and 180 adolescent girls without PMS were studied. Respondents completed the demographic questionnaire, premenstrual syndrome symptom daily records scale, and the medical study short form SF36. So these were the results. Compared with the healthy adolescents, the girls with PMS had a lower SF36 score in all the scales. And this was significant because p-value is less than 0.05. Also, a statistically meaningful difference was observed in the mental health and vitality, energy, stamina of the girls who were suffering as shown in SF36 form as compared to the mild and moderate PMS, the severe form of PMS, there was a statistically meaningful difference. So in conclusion, premenstrual syndrome is associated with substantial burden on quality of life in adolescents, and in addition, increasing severity in PMS symptoms results in decreased quality of mental health and vitality. They concluded this. This was a study. They studied the effects of mastalgia in young women on quality of life, depression, and anxiety levels. 40 females, premenopausal patients between the ages of 20 to 40 years with mastalgia, and 40 totally healthy volunteers with the same characteristics were studied. They were investigated with the SF36 form, Hamilton Depression Scale, and the Hamilton Anxiety Rating Scale, prospectively following breast examination and radiological examination. Anxiety levels were observed to be higher in the patient group The depression level was higher in the patient group. However, this was not statistically significant. The quality of life of the Mastalgia group was determined to be lower than that of the control group. The subparameters of physical function, body pain, general health, and energy were found to be significantly low in the patient group. All the p-values less than 0.05, they are all significant. So they concluded that there may be a relationship between Mastalgia and depression in young women with Mastalgia. However, a closer relationship between anxiety and Mastalgia was observed. Mastalgia did affect the quality of life of the suffering people negatively with a significant degree. So this shows briefly the management of PMS. We start with lifestyle changes such as quitting smoking, alcohol, dietary changes, meditation, relaxation techniques. They can be tried when the symptoms are mild. Otherwise, you can use some medications. First of all, you use nutraceuticals, vitamins and minerals, and then we go on to pharmacotherapy. So hormonal contraceptives. Now, hormonal contraceptives, only this progestin, drospirenone, and a low-dose estrogen combination has shown to help these women. Antidepressants for relief of severe mental symptoms, painkillers to reduce inflammation, block pain, and block the production of prostaglandins, which are causing the pain. Diuretics will help with the swollen and sore breasts. However, all of these medications have side effects and they do not suit everyone. Mastalgia management will include reassurance to those who have no abnormality detected on clinical or ultrasound assessment of the breasts. Now, majority of the women feel comfortable and at ease once cancer of the breast is ruled out. So reassurance is a major part of treatment for cyclical Mastalgia. Lifestyle changes will of course help the patient. 4 weeks of relaxation techniques and good support to the breast will always help. Simple medications can be used like NSAIDs, diuretics, abstinence from foods containing methylxanthines. Now, these are the foods like teas, coffees, chocolates, coconuts, and sometimes vitamin B6 supplement will also help these patients. So this is a flowchart which tells you how you go about Mastalgia patients. If the patient is complaining of breast pain, you do the history taking, physical examination. If the patient is less than 35 years old, and if everything is normal in history and physical examination, then you reassure the patient. And 90% of the women will fall in this category. Their physical examination and ultrasound breast will come out to be normal. Patient is aged more than 35 years, then get a mammogram done. If it comes normal, then reassure the patient. Almost 10% of patients will have persisting pain. Then you ask the patient to analyze her pain score by a visual analog scale. And you may try evening primrose oil or simple analgesics. And this will provide relief to 50% patients. And the remaining, if there is no relief and there are disabling symptoms, then you can try different forms of pharmacotherapy. Danazol is one of them. So these are the different pharmacotherapy for cyclic Mastalgia: tamoxifen, danazol, and bromocriptine. So tamoxifen relieves cyclical Mastalgia in almost 80% patients, but it causes irregular menses and hot flushes. Danazol will have the side effect of mild androgenism. Hair growth, weight gain, and menstrual irregularities will be seen as a side effect. Bromocriptine will stimulate the dopaminergic receptors and blocks the release of prolactin. And it can be useful, but it has shown serious side effects. So all these hormonal replacement therapies have variable effects in different women, but due to the risk of side effects, hormonal medications should be used only for short periods of time. Now, what is the role of evening primrose oil? Primrose is a herb from the Ornithera biennis family. The seeds of the flower contain 2 essential fatty acids, linoleic acid and gamma-linoleic acid. They facilitate the prostaglandin E1 synthesis, which is a good prostaglandin. Now, EPO or evening primrose oil contains 74% linoleic acid, 11% oleic acid, 6% palmitic acid, 2% stearic acid, and 9% gamma linoleic acid. This diverts harmful PGE2 to PGE1 and replenishes the CNS levels of PGE1. So by this action, it will suppress the irritability and depression of PMS and also reduces fluid retention in the breast and mastalgia. Gamma linoleic acid is one of the rare fatty acids which are found in a few plant species only. Evening primrose is regarded as the main source of GLA. Now, there was a study by Watanabe in 2005, and he said that the level of GLA in women with PMS was significantly lower as compared to the control group. It has also been seen that women with mastalgia have usually low concentration of GLA and its metabolites. So it has been used for mastalgia treatment. In this study by Thakur N. et al., the data was collected on a proforma by a resident in the hospital. In addition, a breast pain chart was provided to the patient, which was filled by the patient every day for 6 months to assess the severity of pain. Now, the response to the treatment was graded as excellent, substantial, poor, and no response. EPO was given in the dose of 500 milligram twice daily. 89 subjects were there. And this was the result. There was excellent to substantial pain reduction in 70% patients after 3 months of EPO use. What is the role of vitamin E? Women with dysmenorrhea have a relatively high concentration of PGF2 alpha in menstrual fluid, and suppression of PG synthesis, prostaglandin synthesis, has become the main treatment for dysmenorrhea and PMS. So it is believed that a disturbance of prostaglandin metabolism may contribute to the etiology of PMS. Vitamin E, this inhibits the release of arachidonic acid and the conversion of arachidonic acid to prostaglandins via action on the enzymes phospholipase A2 and cyclooxygenase. Vitamin E also efficiently reduced irritability, stress, and social withdrawal seen during PMS. So this was a study done in Iran, and they evaluated the effects of vitamin D and vitamin E supplements on premenstrual syndrome, and they did a randomized double-blind controlled trial. So this is the best form of study which can be done. The participants were asked to regularly record their daily symptoms and take the tablet, either vitamin D and vitamin E. They were divided into groups, and they were taking tablets for 2 months. 86 women were studied. Dosage was 200 milligram vitamin D or 100 milligram vitamin E, and the third group had no medicines given. So vitamin E showed maximum reduction in PMS symptoms, especially depression-related symptoms. So as you can see in the chart, there is some reduction with vitamin D also, but vitamin E has been shown to be better for depression. What is the role of vitamin B6? Now, vitamin B6 helps make happy neurotransmitters such as dopamine and serotonin. Increased levels of dopamine and serotonin, which improves the PMS symptoms. So researchers believe that vitamin B6 deficiency decreases dopamine in the kidneys and therefore increases sodium excretion, which in turn causes water accumulation in the body, and this will induce symptoms such as swelling in the extremities, edema, abdominal, chest wall, and breasts. Dopamine regulates motivation, cognition, and pleasure. Everybody knows this. Serotonin regulates mood, appetite, sleep, memory, and sexual desire. So B6 has proven to has a good role in synthesis of prostaglandin and fatty acids. So it has a good action on PMS symptoms. So treatment strategies for PMS. First line, we have to ask the patient to follow certain lifestyle modifications. She can have plenty of fluids. She can try herbal teas, chamomile tea, which decrease the stress. Balanced diet, healthy nutrition, and timely meals. The patient has to cut back or prohibit totally the sugars, excessive salt intake, caffeine, alcohol, and smoking. Sleep hygiene should be practiced, adequate sleep, good quality sleep, and timely sleep. Self-care routine should be followed regularly in the form of exercise, relaxation techniques, and social interactions, which form a very good method to reduce your symptoms. Heat wraps or heating pads can be used for pain. Second line treatment, nutraceuticals can be used. Supplements like vitamin B6, vitamin E, vitamin D, calcium, magnesium, folic acid, and evening primrose oil supplements. Now, if the symptoms do not improve with these two first and second line strategies, we can start her on some medications. NSAIDs for pain relief, mefenamic acid, ibuprofen, aspirin, acetaminophen, diuretics, spironolactone, anti-anxiety medications. Now, there's only one contraceptive pill which has drospirenone 3 milligram and ethinyl estradiol 0.02 milligram, comes by the name of Yaz. This has shown some effect in PMS symptoms. And lastly, SSRIs, selective serotonin reuptake inhibitors, or selective norepinephrine reuptake inhibitors will help. So this is the slide which shows you the treatment efficacy of different treatment modalities we have. Not effective, progesterone, predoxin, bromocriptine, OCPs, they have shown to be usually not effective. Possibly effective, dietary modifications, regular isotonic aerobic exercises, psychological approaches, magnesium intake, evening primrose oil, vitamin E, spironolactone, NSAIDs, and Yaz. These are possibly effective. And definitely effective include calcium and SSRIs. So a word about premenstrual dysphoric disorder. This is a severe form of PMS with the same etiology and pathogenesis. It has severe symptoms, clinical depression, panic attacks, suicidal ideation, apathy, insomnia, or crying spells. Now, in this case, psychiatrist reference and consultation is highly recommended, and it is a must. Often the patient will be given antidepressants, anti-anxiety medications, SSRIs, SNRIs, and sometimes cognitive behavioral therapy will be instituted with the patient participating in her own treatment. And she will learn coping skills, coping mechanisms, how she can cope with distressing thoughts and emotions which come with these somatic and behavioral symptoms of PMDD. So take-home message, PMS often improves with treatment. A gynecologist can do a proper checkup and pelvic examination to rule out pathology and offer a personalized guidance and treatment plan that can make a difference for the patient. It's always best to connect with a healthcare professional and specialist if you have PMS. PMS should not be ignored or normalized because it affects the quality of life and living, plus relationships and working of the patient. This is all. We can have some discussion now, maybe.
Hello.
Hello.
Yes, madam. There are some questions also now.
Hello, yes.
Yeah, madam. There are some questions now.
Yeah, sure.
Yeah. I will post one by one question in the chat.
Okay, in the chat. Okay, I should open the chat now, maybe.
Madam, I posted the first question.
Okay. So should I speak or should I tell or should I type?
No. You have to read the question and you have to answer the same.
Okay. So the first question is, what is premenstrual dysphoric disorder? See, premenstrual dysphoric disorder is a type of psychiatric illness which is related to the menstrual cycle. It is often seen premenstrually, and it is a severe form of PMS. So in this case, you should go to a psychiatrist as well as a gynecologist. Both will come together and give some medications for amelioration of your symptoms. Next question. What dietary supplements help with PMS symptoms? So as I have told in the slides, dietary supplements like calcium intake, evening primrose oil, vitamin E, vitamin B6, all these will help if you take these supplements or if you take the foods containing these supplements. And you should often avoid excessive tea intake, excessive coffee intake, and alcohol and smoking. Next question is, how can PMS make other health conditions worse? Okay. So if you are having some other condition, and if on that top of that you have some PMS symptoms, you may have an exacerbation of pathology, like if you have endometriosis, or if you have fibroids, or if you have adenomyosis, you will have increased pain in the premenstrual phase. Or if you have some kind of anxiety or some kind of mood disorder, maybe borderline personality disorder, and with PMS, you will have exacerbation or increase in those behavioral affective symptoms as well. Next, when PMS is so severe that it significantly interferes, what diagnosis should be considered? See, severe PMS is PMS only, and if you are not benefited by lifestyle changes, lifestyle modifications, dietary modifications, exercise, nutraceuticals, then we can give you some medicines. Diagnosis will be the same, PMS.
Hello.
Yeah.
Yes, madam. We are done with all the questions now. And,
Okay.
And thank you very much, madam, for your valuable time and sharing important insights on the topic.
Okay. Thank you.
Yeah, madam. Thank you.